I certainly can speak to the role of the AHA registry along with Mitch. Can't speak for the AHA directly as I'm functioning as a volunteer, but I could definitely give input from our perspective as questions arise.
Okay, because I think if we can have you participate that way, it'll be very important, if you don't mind.
Great. Well, I agree with Mitch. It's a very productive discussion, always is. And I'm going to make this relatively brief at the end of the day. And many of the points that we've discussed, I think, are very academic in nature. And so you'll find that a lot of these points are reiterated through everything we've talked about. I think we've made it pretty clear that get with the lack of guidelines is part of the problem. It's why we're all here. And Sean laid this out very nicely in 2019, the amount of white space in the shock management guidelines. I think one of the major problems in the RCT space, and this is why I'm thrilled that Abumet has taken up the heavy mantle of running the RCT, is the challenge of the cookie cutter approach with designing shock trials. These are not drugs; these are devices. They carry with them. They are simply tools in a toolbox, and as a result, you have to really make sure you're implementing it as part of a system. And so when we look at the different components of managing a shock patient and trying to put this into a RCT, the randomization, regardless of trying to figure out, first of all, the target population, but then the randomization to insert any device here versus do not insert any device here, really is very limiting in nature. The hemodynamic assessment, the limb protection plans, the escalation, the management targets, optimizing the current standard of care, device de-escalation, the device explant, and then the anticipated treatment effect make these RCTs extremely challenging to design, and really it's a leap of faith, I would say, with R4. There's a lot of data to support its development, but nonetheless, it's constantly changing. When you look at the danger shock trial, we're thrilled that this trial is coming near to conclusion. And if you look at those ultimate components of the RCT that are required to be developed, you can see here that the Impella pre-PCI versus standard of care, avoid Impella, with some limited protocols being implemented, is really probably one of the most contemporary trials to implement algorithms. And the challenge here, of course, is they're going after a 180-day mortality effect, 18% treatment effect is what they calculated to in danger. So this is another challenging RCT. It's taken Jacob Moeller, I think, almost 12 years to get to this point where he's nearing the end finally. But one of the really important aspects of this trial was that it was the first to test algorithms of care. And I think herein lies the academic opportunity. There are things that we're doing already in clinical medicine and clinical practice that can be randomized that are basically part of this pragmatic trial approach. And we'll talk about one of them that we're doing in just a moment. But if you think about this type of algorithm, stable hemodynamics, unstable hemodynamics, consider this, consider that, and then all the different escalation components, this now is going to be really fast-forwarded in the R4 trial design to get extremely granular around protocolizing every aspect of the trial. In R4, as you've heard earlier today from Greg, this is basically a pre-PCI Impella algorithm built off the NCSI data for patients with STEMI or STEMI equivalent shock. So I think it's really important to, again, emphasize the heart failure shock population is radically different. This algorithm would have almost no bearing on a heart failure shock patient. And so that's really, really important when we start thinking about how this data may be utilized or how the algorithms may be utilized. The definition of shock, and I think there was a lot of collaboration around the SHARC definitions as well as around EFIC for SHARC, was really important in R4 design. And what we're seeing here is an estimated reduced absolute 30-day mortality. Right now is calculated around 13.5%, so it'll be 548 total subjects to achieve 90% power. The main thing that we spent an inordinate amount of time on here is basically the development of algorithms upon algorithms. So what you're seeing here actually are in this micro print, which we won't get into, is what we're asking clinicians to do now is to now protocolize their behavior. And I think it's important to recognize that the upfront behavior is different from what happens at 24 hours, what happens at 48 hours. So there is leeway. The idea that you need to mandatorily go to a 5.5, mandatorily go to an RP, there's leeway always in there because ECMO is actually built in on both sides. So I think there's some opportunity for operators to make decisions, but within the confines of a protocol. One of the most important aspects of this algorithm however, is on the far right side, and this is the intra-cath lab management of the patient at the time of index STEMI. And this, I think, is really important because, as we said, a lot of what happens in the first hour is really going to impact what's going to happen over the next 2 days. And leaving the cath lab with optimal limb perfusion, with hemodynamic targets met, with escalation before you leave the lab, and then with a plan on how you manage the patient in the critical care unit is really, really what I think makes R4 very exciting. So when we take a look at what we looked at for all the elements of an optimal RCT, everything is now protocolized, all the way down to limb preservation, targets of therapy, de-escalation, weaning algorithms. We had 3 critical care cardiac intensivists look at the protocol and make sure we had weigh-in on a multidisciplinary team. So that's an RCT, but I think, to be honest with you, one of the opportunities here, I think, for the registry groups is the implementation of pragmatic clinical trials. We talked a lot about that this morning in the sessions I couldn't attend due to conflicts here. But I think this is a huge opportunity for academia to step in. As we just talked about, and as I've been emphasizing throughout the meeting, shock management today is Russian roulette. It basically is, let's see what happens, who's there, and what are we planning to do. The algorithms that are in clinical practice are things that I think we can start to triangulate around. So this has become quite a focus for the shock working group. We're now over 7,000 patients, with over 1,000 patients with 30-day, 1-year follow-up, now expanding outside the U.S. And the data that we're collecting, it's really, our focus is not on quantity of sites, but it's the quality of the data that comes in. The CRF is extremely granular, so there is no lean CRF in shock working group. Our coordinators and CRCs meet monthly for therapy on how to get all that data in there. But the data that we're beginning to unearth, I think, is starting to really help us understand pragmatic RCTs. So when we looked at this issue of transfer patients, it became really clear, actually, that about half the population that's in the shock working registry is transferred from an outside hospital to the hub site. And when we looked at the heart failure patients, the one technology that actually led to a reduction in the hazard ratio for mortality was early use of a PA catheter. PA catheter insertion at an outside hospital or within 24 hours of arrival to the shock working group site. That was the odds ratio. Now, when you look at the MI group, actually PA catheter did not show up on the multivariable analysis as making a difference. But what did make a difference was early implementation of MCS. And so this is now looking across about 5,100 patients dichotomized between heart failure, MI. And I think this is where the opportunity starts to lie in terms of how we inform the development of future RCTs. A major focus for us in the working group is in heart failure shock, because we think that's a really untapped domain that requires a lot of work in the space right now. And when we saw the 2022 heart failure guidelines downgrade PA catheter use from a 1C to a 2B recommendation, driven by the level of evidence, NR, no randomization, that's when we got very concerned. And when we look at the pie chart, what you see in black is the amount of PA catheter use in the registry, so a substantial amount of use, differentiated primarily in the blue, which is heart failure shock. And if you look at the mortality bar graphs, it's heart failure shock that's driving the reduction in mortality when you have a PA catheter in place. MI shock, not quite. It doesn't make as much of a difference. But what we see here actually now in the forest plot is it's about the timing of that assessment. If you get that PA catheter within 6 hours of shock diagnosis, the odds ratio favors survival versus if you get it after 48 hours. So as we started to put our heads together, and credit to Joe Massaro, who passed this past year, was extremely helpful in designing the RCT for the PAX trial, and in honor of Joe, we hope to get this trial done. The PAX trial now is taking patients with heart failure shock, de novo or acute on chronic heart failure, who come in with HFrEF. These patients meet criteria, we get consent, they're randomized to PA catheter insertion within 6 hours, or they get no PA catheter, but everything else under the sun. A central line, RA sat, estimated cardiac index, A lines, estimated cardiac output measures, whatever you want to do. And then we did leave an exit strategy for the heart failure physicians who desperately need their PA catheter. They can put it in after 48 hours if they're randomized into the no-PAC arm. One of the interesting things after we've launched this trial is the fact that we're starting to learn about the variations in practice. So a lot of the centers that are in the shock working group are academic centers. These programs are VAD transplant programs. So getting out into the community, as I described, the community hospital, which said we don't manage PACs in our ICU, this is really where we think this type of trial should be done. And so now we're starting to branch out beyond the shock working group confines into those community areas to recruit for this trial. So we'll provide you guys an update in 1 year, but I think this is an example of an academically driven, pragmatic trial that allows us to take a critical decision-making point based on registry data and design the trial around the registry data to try to hit the sweet spot about early invasive hemodynamic assessment and heart failure shock. And I think we can do this over and over again with combined data from the registries as we learn more. Thanks very much.